Hello, how are you? I'm going to discuss today about acoustic neuroma. Acoustic neuroma is a benign tumor that arises from abnormally proliferative Schwann cells that envelop the vestibular nerve in the internal auditory canal. It has some other names. This is also called vestibular schwannoma, eighth nerve tumor, or neurilemoma. Actually, acoustic neuroma is misnomer. It should be appropriately called vestibular schwannoma. Its incidence is 2 in 2 lakh. It constitutes about 80% of the cerebellopontine angle tumor and 10% of the intracranial tumor. Now come to the etiology. Its etiology is mostly unknown. There may be association of chromosome 22q defect. Now come to the characteristics of the tumor. It is benign, it is slow growing tumor, it is encapsulated tumor, and it is mostly unilateral tumor. Some varieties, that is 5% of vestibular schwannoma or acoustic neuroma, is associated with neurofibromatosis. This variety of acoustic neuroma is bilateral, maybe even multiple, and these are more aggressive, and this may appear early in life, like second to third decade, and this is called von Recklinghausen disease. Now come to the origin of the tumor. When the eighth cranial nerve exits from the cerebellopontine angle, then it enters into the internal auditory canal. Here lies the transition zone between the central myelination and peripheral myelination. This is called Orber-Steiner-Redlich zone. Vestibular schwannoma arises from this zone. So this zone is the medial end of the internal auditory canal, and that is close to the lateral end of the cerebellopontine angle, and internal auditory canal is divided into 4 quadrants by 2 ridges. The seventh nerve lies in the anterior superior spect. The cochlear nerve lies in the anterior inferior spect. The superior vestibular nerve lies in the posterior superior spect, and below it lies the inferior vestibular nerve. And the vestibular schwannoma most commonly arises from the superior vestibular nerve. Now, growth of the tumor. When the tumor grows, first it tries to grow within the internal auditory canal. Then when the bone resorption occurs, it comes out of the internal auditory canal, and then it may affect anterosuperiorly the 5th cranial nerve. It may affect the inferiorly the 9th, 10th, 11th nerve, and when it is large enough, it can cause pressure over the brainstem and cerebellum. Now, if we come to the clinical feature, it is mostly unilateral and sporadic variety, as I told earlier, and age is between 40 to 60 years of ages, and when it is von Recklinghausen disease that is associated with neurofibromatosis, the age may be earlier, that is second decade or third decade of life. Males and females both are equally affected. Number 2 is the vestibulocochlear symptoms. It is the earliest symptoms that patient presents with when the tumor is still intracanaliculaar. The symptom is progressive unilateral sensory neural hearing loss with or without tinnitus. 90% of patients present with these symptoms. There is a marked difficulty in understanding the speech out of proportion of the sensory neural hearing loss. It is the characteristic feature of the acoustic neuroma. And some patients, about 10% patients, may present with hearing loss that may be profound. Some patient presents with vestibular symptoms like imbalance, but true vertigo is seldom seen. So in the clinical feature, first we told about the number 1 point age and sex, then number 2 the vestibulocochlear symptoms, then number 3 is the cranial nerve involvement symptoms. The 5th cranial nerve involvement, it is the early nerve to be involved. When it is involved, there is reduced corneal reflex, there is numbness or paresthesia of the face. 7th nerve may be involved. When it is involved, then there is a hypoesthesia of the posterior meatal wall. This is called Heiselberger sign, and there may be reduced taste sensation, and on shimmer test there may be reduced lacrimation. When the 9th and 10th nerve involved, then patient may present with dysphagia or hoarseness due to palatal, pharyngeal and laryngeal paralysis. When the tumor is large enough, it may involve the 11th nerve, 12th nerve, or 3rd nerve, 4th nerve, or 6th nerve. Now, number 4 is the brainstem involvement symptoms. These are ataxia, weakness of the limbs, and tendon reflex may be exaggerated. Number 5, that are cerebellar involvement symptoms. Cerebellar involvement symptoms are revealed by the finger nose test, the Hill
Shin
test,
test.
dysdiadochokinesis, failure to walk along a straight line and tendency to fall on the affected side. Number 6 is the raised intracranial pressure symptoms. There may be headache, nausea, vomiting. There may be blurring of vision with papillary edema. There may be diplopia due to sixth nerve involvement. So what are the investigations we can do? We can do pure tone audiometry. It shows that there is sensorineural hearing loss, which is more marked on the higher frequency. We can do speech audiometry. In speech audiometry, patient will show that there is poor speech discrimination out of proportion of the sensorineural hearing loss. There is a common phenomenon here. It is called rollover phenomenon, which is reduction in discrimination score when the loudness is increased beyond a particular level. We can do stapedial reflex decay test. We can do evoked response audiometry, that is PERA test, P-E-R-A, PERA test. It shows that in presence of 8 nerve tumor, there is difference of more than 0.2 millisecond between the 2 ears in the fifth wave. Imaging that can be done is MRI with gadolinium. It is the gold standard of diagnosis. It can diagnose even the intracanaliculaar tumor. MRI of the internal auditory meatus and the cerebellopontine angle is how we advise. And there is another option called vertebral angiography when there is confusion that the tumor is vestibular schwannoma or other cerebellopontine angle tumor, then we can do it. So what are the differential diagnoses? The cochlear symptoms may be similar to Meniere's disease, so it should be differentiated, and it should be differentiated from other cerebellopontine angle tumors like meningioma, arachnoidal cyst, primary cholesteatoma, aneurysm, glomus tumor, and metastasis. Now come to the treatment. Number 1 is the conservative treatment, that is observation. Interestingly, as the vestibular schwannoma is a very slow growing tumor, so observation with serial MRI is an option here. Most of the about 60% vestibular schwannoma do not grow after the time of the diagnosis. So we can wait, and those that grows at a rate of 2 millimeter size per year. So if we see that the growth is more than 2 to 3 millimeter per year, then intervention is needed. So when we are observing the patient with serial MRI, first interval scan is done at 6 months and symptoms are reviewed. If the condition is static, then we can do a scan every yearly for 5 years. Then if the condition is static, we can do every 2 yearly scan for the next 10 years. Then if the condition is static, we can do scan every 5 years. The number 2 option is the surgery. Surgery is the curative treatment. There are some approaches like medial cranial fossa approach, the translabyrinthine approach, retrosigmoid approach, and combined retrosigmoid and translabyrinthine approach. Retrosigmoid approach is also called suboccipital approach. In translabyrinthine approach, hearing is not preserved, but in other 2 methods, that is retrosigmoid or medial cranial fossa approach, hearing is preserved. Then another option is the gamma knife stereotactic radiosurgery. It is an interesting option. Why it is called stereotactic radiotherapy or radiosurgery? It is called stereotactic because unlike the conventional radiotherapy, the radiation energy is converged onto the tumor. So it is called stereotactic. And why it is called radiosurgery? Because like other surgery, this is done for one time and no other follow-up radiotherapy is needed. So it is called radiosurgery. High energy, high doses of energy can be given to the target tumor to destroy the tumor cells. This is the stereotactic radiosurgery. And why it is called gamma knife? The stereotactic radiosurgery can use 3 types of equipments to deliver the radiotherapy, and gamma knife is one of them. It is the equipment through which the stereotactic radiosurgery is delivered. That's why it is called gamma knife stereotactic radiosurgery. What are the advantages of it? The advantages of it are it can be done as an outdoor procedure, no general anesthesia is required, quick recovery of the patient, less morbidity of the patient, preservation of the surrounding neural structure. CyberKnife is another option. It is the improved version of the gamma knife radiosurgery. Number 4 option is the vestibular physiotherapy. It is needed for the patients that are not undergoing surgery and the patients who have undergone surgery, that is postoperatively. So from the acoustic neuroma, we have learned that any patients with sensorineural hearing loss that is asymmetric and is more pronounced on the higher ranges, and there is poor speech discrimination out of proportion of the hearing loss, we should be suspicious of vestibular schwannoma or acoustic neuroma. We can order MRI here. That's all I have today. Thanks for watching. Goodbye.